First of all, I'd like to thank Shelley for framing our study and connecting it so well in terms of exactly what we're about. The common theme among them is owing to the brilliance of the staff to see how all these are connected when Bob and I are very much embedded in our project that we call Small Troubles Adaptive Responses. We call it the STAR Project, and fostering a quality culture in nursing. And indeed, it is about change, and it is about fostering the nursing engagement and interaction with the hospital system as a system that has a property of quality and safety. So we attempt to engage frontline nursing staff in improving work at and looking at small troubles before they develop into large troubles. And you'll recognize some of the foundational work done by Edmondson and Tucker on that. Our primary objective is to determine if our program of addressing small problems will result in both quantitative outcomes such as hospital safety culture survey improvement, NDNQI variations, and part of the existing information that's already been gathered on the dashboard of the hospitals is an employee engagement survey as well. We're looking at qualitative key informants again and looking at trends in their experience of small troubles in the hospital and the first order operational failures and how we do first order problem solving with those. So where are we? We have completed startup. We've completed startup.
We hope.
We have. Everybody has a sense and nobody's saying it. This was very challenging. We've hired a team. We've oriented that team. We have a specific intervention that we're accompanying on a unit-based level, and it's called the practice facilitator. That's an intervention that's being used in primary care, and we're intervening on the hospital units with this particular role. And we did IRB approval, IRB approval, IRB approval. We thought we were going to do, we thought we were going to be exempt, and certainly we were expedited with written informed consent. We've gotten administrative buy-in. That seemed to be like the greased path here, and we thought, wow, it's going to go really, really well. In one of the two hospitals, we've gathered baseline quantitative data, and we're in the startup of qualitative as it is in progress at this point. And what have we learned? Oh, let me back up one more. That particular logo is a piece of what we've learned. It's our small public relations advertising attempt. We are academicians, and we're newly partnering with our hospital laboratory, and we're emphasizing the partnership there. This very small logo we place on every piece of information that goes out about the study to engage the nurses at the front line to participate in it. And to tell you the truth, in this hyper-stimulated environment, it's like a guppy in the ocean. We have, to contend with many, many postings on bulletin boards and coffee rooms and people that come up and show up on the unit. We did think that the leadership enthusiasm was fabulous when we started out. We found that it does not transfer to frontline enthusiasm. I think there's interest there. There's just the work culture is not embracing of this. We had an assumption about the channels to reach all nursing staff, and we really were surprised and finally sat down in terms of thinking about why we were having difficulties. At the hospital leadership's recommendation, we said we'd have a meeting. We'd have 4 meetings to get off-peak people to come in and provide data, and we found out that if you have a meeting, we thought they would come and they didn't. We thought that if you hung out in their coffee room, they would complete surveys and show up, and they didn't. We thought that if you email them, they will read it, and they didn't necessarily do that. We thought finally if we shadowed them, and there's police reports about that, shadowing people too closely. If you shadow them on the units and offer them high-end chocolate, they will engage. Seriously, this is an environment where staff had been engaging in surveys to get a complete profile, and the hospital itself offered high-end incentives. and we entered in with, our candy kisses and little glass stars. So that was a big culture learning for us. The staff were acclimated to the valuable participation rewards. The trust issues that were unrelated to the study are part of this growing and evolving hospital. About half of the 350 nursing staff who were eligible to participate showed up at one of the meetings or were found in the coffee rooms. Of those who were invited to participate, actually showing up and looking at the consent form, only half of those decided to provide data in the survey. That was the new piece to the entire profiling. So that was very interesting. The unit level focus clashes with individual consent, and when we went in with complex adaptive systems as a framework, we decided we'd analyze aggregate data across 12 units, 6 in the intervention and 6 in the comparison. And you don't ask a unit for consent on these things. IRB says you have to ask each individual. So that's been a very interesting challenge to step through. I think that our key lesson is it's very challenging to build this new awareness about the study, even though it is part of what the hospital is launching out to do on their journey to Magnet. And the idea that all of our jobs as health professions is to do our job and to improve our job. And I think it's the second part that we really don't have a true integration yet of. So why does anyone care? We happen to have a Clinical and Translational Science Award at the Health Science Center. This hospital locally is one of our outreach communities that we've already begun for about a year and a half to change the dynamics in our local community in the South Texas Health Medical Center and to engage hospitals. They're very interested. As you know, 1 year isn't a long time to change culture. I think the fact that magnet recognition programs are catalyzing interest in quality improvement and patient safety is certainly part of why they care, not just to get the recognition, but for all the underlying evidence that it offers in terms of improving mortality and morbidity of our patients. And the other engagement that was very interesting is that leaders from both hospitals that are part of our study presented last week at our quality improvement conference that attracted 450 people nationally, which is a change in our local community. Both Austin and San Antonio are engaging in this. So we see these movements forward, and hospital systems are caring. And the larger tomorrow message, when we actually have all the data and findings and look at these things, is why does anyone care? And that would be we would want nursing frontline staff members to move to second-order problem solving, because that increases the learning organization and quality and safety. Our hopes for the future are to expand this academic service partnership. We have very much support through our CTSA to get these quality indicators on the dashboard and use them as valid data for improvement research, meaning that our hospitals become a viable laboratory for this kind of improvement research. To splice back together the academic researcher and the practitioner split, and to develop the baseline in the system for what kind of intervention actually works. Our team is identified. Dr. Frere and I have worked together for 8 years in the area of quality improvement, largely in putting together systematic reviews and offering a quality improvement conference. So our partnership was fairly natural in terms of moving forward. Dr. Arar has been part of the critical mass in San Antonio looking at the VA quality improvement initiatives, and she's a medical anthropologist. And then the two research associates, Amanda and Nicole, are, interestingly enough, from newly graduated from our School of Public Health, a master's in public health, and our program has a heavy emphasis on organizational behavior. And while they didn't know necessarily the project or the foundations that we were dealing with, they had that larger paradigm of organizations and communities as the touchstone for pure change. So that represents where we are today, and we have our trips up to Austin now to launch the second hospital. Thank you.